Thank you. Okay, floor's yours, Sam.
Okay. Let's see. Are you seeing the slide?
Not yet.
Oops. How about now?
Nope.
Give me a second. Huh?
And we can always advance for you too, Sam, if you'd like, if you want to send it to one of us, but
Yeah, maybe I should do that.
no problem.
I'm happy to do it if you need.
Okay. Okay. So I've just sent it to you, Mark and Vivian.
Okay. I'm waiting to see it come in.
So while we're waiting to set up, I know, Anne, it sounds like you and Amanda are thinking of a prediction, doing some prediction modeling work. And Sepley, were you interested too as well? Do you have something?
Yeah, we've submitted grants before that included using prediction models, using a number of different clinical and non-clinical variables.
Okay. So my intent is to, to make this about half an hour, 40 minutes, and have some time for questions. Because I'm just going to be covering, just giving a broad overview today.
I have not received your email yet, Sam. Sorry.
Ah.
I have it here, so I can share my slides or the screen now.
Thanks, Vivian.
Nice.
Perfect. Sam, you're able to see?
Yep.
Okay.
You can see it. Okay, thanks. So, so I chose this topic because we have these great databases around BC cohort, MacWise, increasingly medical record data is available, and prediction models can be based on just plain old research databases. They don't necessarily have to be based on giant cohort or medical record systems, and they're being produced a lot. I actually don't know how much they're being used. I think it depends on the field. So, if there's time at the end for a discussion, I'd be curious to find out how much they actually are being used. So, next slide. So, so few different subtopics here. So, I wanted to clarify for people who aren't aware, for people who already know about regression modeling, how prediction modeling is different, even though it uses in many cases the same tools for regression modeling, but you use them differently and you select variables differently and evaluate them differently. And there are different stages that have been recommended for sort of a full development of the prediction model. Think of it a little bit like stages for a new drug, where there's sort of this laboratory type stage, and then preclinical research, and then phase 1 trials, and phase 2 trials, and phase 3 trials, and then it gets approved by the FDA. So it's not exactly the same full process, but these stages are they're sort of ideal stages, I guess. I'll present a little graphic that I produced to sort of help think about what absolute risk means, and how a model helps to sort of shift the absolute risk estimates away from the average. Talk very briefly, and just mentioning the different regression approaches and other approaches that are available for developing a model, and there are many. And how to evaluate a prediction model, and that's a little bit different than standard regression models. A little bit of guidance on sample size requirements and some general recommendations. So next slide. So so usually most prediction models, I think, that are used in public health and medicine tend to focus on a binary outcome measure. So in that sense, they're risk prediction models, or they're estimating the probability that a patient, say, will have a particular event, at some point in time. It could be, a negative event, disease exacerbation, developing a malignancy, developing dementia. It could be something positive, achieving cure. Hopefully the basic science people and our CFAR will move things along, that someday we're talking about, figuring out who is cured more quickly than others. It could be a behavioral outcome, such as adherence. And you can use it with survival type models, where you actually have a time-related outcome as well. And continuous scores. It's not used so much for that, but there's no reason you couldn't do it to, say, predict what someone's depression score will be after they've been in treatment for something or other for 6 months, or sort of a more health policy type question. What is the expected number of emergency department visits for a particular patient, given what we know about them? And prediction models can be used for not just clinical decision making, but sometimes it's useful for patients to know what to give them sort of a risk estimate for what they can expect. It could be used by a program, a social program that has, say, if they're trying to decide, well, which patient should I select into the more expensive, resource-intensive program to help prevent, lack of adherence in their HIV medicines, and we only want to select people who are at the highest risk levels, and can we do this in some objective way in advance? And it's not done frequently, but in theory, it can be used, and I think it has been used sometimes in designing clinical trials as an inclusion criteria. So, one of the criteria is that a patient must have an estimated risk of having a particular outcome of at least, 30% or 20% or 90% or something like that. So think broadly about how you can use these kinds of models. Next slide. So this is just a screenshot of commonly used prediction model based on the Framingham study, and there are different variations of it, and I assume it's still used currently in primary care practices, for example, to decide whether a patient, should be put on some sort of medical therapy to help prevent cardiovascular events. So here you just, you just feed in the information, assuming you have all the information, and out comes the estimated probability that that you would have a cardiovascular heart event, in the next 10 years or something like that. So, and behind the screen here, of course, is basically a formula. Next slide. So, so I just want to clarify for those who aren't clear about this, about how even though you might be using the same regression modeling tools for a prediction model as you would for other purposes, it's still a different process. So the software might be the same software, the output may look the same, but there's really more to it for a prediction model where you're talking about estimating really the absolute value of a probability in case of a binary variable that someone has a particular condition or has a particular risk. As opposed to the much more common use of regression modeling, which I label here number 2, sort of descriptive, meaning, what are the risk factors for having a particular event. So, if we're looking for risk factors, we're not trying necessarily to predict an individual person's specific risk. We just want to find out, well, which variables are most important. And the conclusion of that might be that, well, we think that, we found that the following 5 variables are seem to be pretty important in terms of risk, and maybe the others aren't so important. And, and many times that's really all you need. But, and we also use those kinds of regression models to kind of deal with causality, even though we may not use the term causality. So we say, well, what happens, is there an association between stress and becoming non-adherent on HIV medication? And we want to control for all these other confounding variables. So the underlying idea there is that we want to explain something in a causal sense. Now, you can have the same regression model that can serve all 3 of these purposes, but oftentimes the models would be set up a little bit differently. So if it's a prediction model, you don't have to include variables that you can include variables that don't make any sense in terms of causality or even in terms of descriptive epidemiology. So I don't know. Here's just an example off the top of my head. Let's say that you're doing a study to predict whether a patient is likely to become non-adherent on their HIV medication over the next 12 months. And you go to your electronic health record and you just say, I'm just going to toss everything into the model. And one of the variables is whether someone has had a diagnosis of severe hypertension, that is a diagnostic category, and is currently their last few blood pressures have been well in the normal range. Well, my guess in that case is that that variable actually might be predictive of being adherent to medication. It doesn't make any sense in a causal sense, like you wouldn't prescribe if they're on anti-hypertension medicine, to achieve that, you wouldn't prescribe that to make them more adherent to their HIV medicines, but it still might be correlated with the outcome because people who are on antihypertension medicines and have it under control may in fact be just sort of both able and willing to to participate more fully with the recommendations of their healthcare providers. So there's no harm in including that kind of variable in a prediction model. Personally, this is just sort of a gut feeling, is that I think that variables, I would be more trusting of variables that I think are causally related to the outcome than I would of variables that I think are just sort of correlated because they're correlated with some other variable that really is important. But there's no actually requirement to say that, again, it has to be causally connected to the outcome or really make any sense as long as it works. By the way, do feel free to stop me at any time if you have any specific question or questions in the chat. So let's move on to the next slide here. So I've sort of put this modeling stage. This is my own sort of set of bullets. It's derived from other things that I've read in the prediction modeling literature, and it kind of represents an ideal that's only occasionally achieved. So the first stage is really just trying to figure out what variables might be correlated with the outcome of interest, and not necessarily even putting together a model at that stage. So a lot of, there are a lot of papers that are done on that now, and they get published, and I think they're important to do. For those of you who, after seeing the rest of my presentation, decide that, well, a full prediction model maybe is more than I want to get into, stopping at this stage, I think, there's nothing wrong with that. Just realizing basically we're looking for variables that are, somewhat substantially associated with the outcome. If they're trivially associated with the outcome, then, they're only going to trivially help in terms of prediction. So the next stage is actually developing a model, and I'll talk about that in the next few slides, the actual process. So I have seen a pretty strong recommendation, which I hadn't noticed before, which says that if you're going to develop a prediction model and publish it, that you should also do an internal validation as well. And I'm not sure that's actually essential, but since that's the recommendation, it's not a bad idea. And by internal validation, you're talking about something it's a little bit technical. It's doing either dividing your sample into a training data, what's called a training data set, and a validation data set. So maybe 2/3 of the sample is where you develop the model, and then you see how well it performs in the remaining third. That's kind of the typical way it's done. What's more preferred are methods, sort of more modern methods, such as the bootstrap and resampling methods, as well as the k-fold cross-validation approach. And those are, I can talk about them more later if people have questions about them. They're not that difficult to implement, and you do need to have a little bit more than basic computer skills to do them. Depends what software you're using. So another stage is an external validation. So what happens too frequently is you do the study, you develop a model in your sample, and then people try it out elsewhere, and maybe it doesn't work so well. So, and the internal validation part of the bootstrapping and cross-validation can help, but it still might not make the model really work well elsewhere. And that's really, it's really quite important for ultimately to have these models validated in other samples. And there are often good reasons to think that they may not work so well necessarily in other samples. And that's something that can be done by you if you have access to other samples, but it might be done in completely separate studies that are done by other people. Or you could do, if you see a model that's been published based on another sample and you have access to the DC cohort and has the data you need or map lines or something, and you say, hey, I wonder how well it's going to work in these cohorts. Well, you know, that could be a paper by itself just to see how well it works. I think that's it's an important kind of paper, I think, to do. When that kind of external validation is done, the if you're finding, you might find, for example, that the model works pretty well in terms of separating people, called discrimination. I'll talk about that in a minute, but it may not calibrate well. In other words, your model may say that someone with a particular set of characteristics has a 20% chance of an event, whereas the other sample might have a 40% chance for that same set of characteristics. And maybe it's because that other sample is a higher risk population than the one you're working with. So so there are actually methods where you can update your model to sort of compensate for those between sample differences. So hopefully it'll work well on that other sample. There are also I don't list it here, but I know that there has been work going on where people have sort of continually updated models. So you're working in a particular hospital system, and you have a model that's based on the patients in your hospital or outpatients, and the concern is that the patient characteristics change over time, the conditions change over time, not just their separate characteristics, not necessarily their demographic characteristics, but maybe their clinical characteristics change over time. Maybe you're getting patients who are referred to your hospital or clinic that are at greater risk or lesser risk, or there are other treatment changes that are going on generally that affect the overall risk level. So there are systems where the actual prediction model is sort of automatically updated, by the day, the week, or the month, of the year. I don't know those models specific, directly. I don't have direct contact with them, but they are seen as sort of a wave of the future. And finally, the last stage that's listed here is testing the model impact via randomized controlled trials, et cetera. So I'm not sure how often this is done. I've never actually seen a paper doing this, but the idea is, well, if you think your model is so great and is really helping patients, well, it means that patients who are using that model, or their providers are using that model, should have better outcomes than patients who are not using the model. So why not randomly assign people to either use the model or use sort of standard of care approaches? And the one case I can think of where maybe that was done was, I know in oncology and in breast cancer, maybe 15 years ago, they started to develop, private companies were developing these genetic risk factors, risk score models that were kind of proprietary. And I'm thinking maybe the FDA may have required them to do some sort of clinical trial before being able to market them commercially. Anyway, that's something that's probably way beyond anything that people in this group are thinking about at the moment. Next slide. So I don't know, I was playing around with just sort of a kind of a graphic way of explaining some concepts. I don't know if this will work or not, so don't take it too seriously. But so supposing you have a population that you've defined, and maybe it's everyone in a database who is an adult person living with HIV who's seeing a healthcare provider, and you want to see if they have some sort of event in the next 12 months. And so that second column, you'll see the A. So think of that as sort of model A. All you knew about that population was that 34% of the people in that population had the event. That would be your best guess as to their probability that that person at random from the population in the future is going to have that event in 12 months. So, but as you start adding variables to the model, the idea is to, for specific groups, to be able to move that probability up or down. And the closer you can get those estimated probabilities to either 1.0 or 0.0, kind of the more useful the model is. So, so supposing you say, okay, I'm going to put age in the model, and I just selected for illustration a value of someone with an age of 50, which is the B1. So let's say you had an unlimited sample size. So we're not worrying about sampling error. So 42, let's say you find that 42% of those with an age of 50 have the event. So that's clearly increased. That's been of some value, right? You've increased the estimate from 34% to 42%. Is that enough to be useful to you or to a user? I don't know. It really depends on the purpose. You would hear me say that again. Someone has an age of 30, it reduces their risk to 26%, which, again, is not trivial to me, but maybe in some contexts it is trivial. Now, supposing you have another variable added to the model, which is years since they were diagnosed with HIV. And so in C1, I've taken the estimated probability for that person who was diagnosed 22 years ago. And you'll see there that it's barely greater than the general risk for someone who's age 50. So it doesn't add very much to it. And you would kind of expect that in a case like this, because age and years since diagnosis in kind of a general adult population are likely to be, moderately highly correlated, right? If you've been diagnosed many years ago, by necessity, you have to be older to, it just one follows from the other. So one little thing to learn from this is that if you have variables that are highly correlated, it's unlikely that adding one to the other is going to make a great deal of difference in terms of the predicted probabilities. It's still adding more variables generally does help, but it may not help very much. And then I said, well, supposing this is some sort of biomarker study and you have a biomarker positive or negative for everyone in the sample. So let's say you add that to the model and you take the same person who's 50 years old, 22 years since they were diagnosed, and their biomarker is positive. Well, that pushes the probability up to 52%. So at that point, you're getting a fair amount of distance between 52% and 34%, which is the overall population. So the more that your model sort of leads to predictions for different groups that are pretty far separated from the average for the whole group, the more valuable the model is. If you had a model and you were to do something like this and you found that for most of the values of the predictor variables that you're interested in, that the predictions are very close to the population value. So let's say that they're all between 32 and 36, right? The average is 34. Well, is that model useful? It's conceivable, it's useful to somebody somewhere, but maybe not so useful. In other words, My focus here really is on whether when are these models practical or not, because using these models doesn't always involves some degree of time and effort. Having a database available, having a provider extract the information or somebody else extract the information from the database and so forth. So let's go on to the next slide. So developing a prediction model. So first, you really do need to be careful to define the population. Yeah.
Do you want questions now or at the end?
Oh, okay. I can take a question now. Let's see.
There was a question regarding, I think, with regards to the previous slide, the model you showed. And it's from Yan.
Yeah. So this is so C1 is just, again, my graphic here is not a perfect tool, but it's saying, well, supposing it's not a mean, it's just saying, just pretend you didn't do any fancy analyses, no regression modeling, no machine learning. Let's pretend that you had a sample size of 20 million or something like that. So we're not worried about sampling error. And you said, well, let's just take everyone in the sample for C1 who's age 50, and it's been 22 years since they were diagnosed with HIV. And perhaps this is what you'd find, that their risk is 44%. So we're not at any kind of modeling stage or anything like that. This is just sort of one way of thinking about prediction models and the concept of discrimination versus calibration, which I'll be talking about a little bit soon. That kind of answer your question, Jan?
Oh yeah, sorry, I was late, so I missed a lot of slides in the previous your presentation. That's the reason when I saw this one, I thought it's based on the regression model, and then you do the prediction based on the value for each predictor. Yeah, maybe I misunderstood that.
Right. So again, that the reason we use the fancy models, which I'll talk about in a minute, is because we don't have an unlimited sample here, right? If we had an unlimited sample, the models may not really be very useful to us. We would simply say, oh, tell us what what the age is in the years since diagnosis and so forth. The models tend to they do better, when the sample size is larger, and they tend to sometimes overestimate risk or vastly underestimate it as you get to the more extremes, right? And that's sort of another point I'd like to make here, and that's where the modeling approach tries to kind of compensate for that and bring things back in to make things a little bit more realistic in terms of the coefficients for the model.
Yeah, thank you so much.
Sure. So why don't we move ahead to, let's see, so you define the population, then you come up with a list of potential predictors, called candidate variables usually. And for each variable you're thinking about, think about how this model might be used in real life. There's no point in putting into the models variables that are kind of not very useful, either because your intended user is just not going to have that available to them in an electronic health record or something like that, or it's it's kind of a junky variable, technical term, because it's got full of missing data and full of measurement error, and it's been misrecorded for it's incorrectly recorded for half the patients. Forget it. Don't use that. Pick variables that you think might be useful and helpful. So then you pick a modeling approach to actually select the variables. So you might start with, say, 20 variables or 30 variables. Sometimes with machine learning, people may start with 3,000 variables, but usually it's a much smaller number, and you want to reduce it usually to those that are kind of most relevant to the most important for prediction. And so there are kind of two basic approaches. One is regression models, which I'll mention in the next slide briefly, but I'll just mention here, and also machine learning techniques. Try not to ask me too many questions, or maybe any questions about machine learning techniques, because that is not my area of expertise. For those of you who are thinking of doing something with machine learning, my colleague, Wally Yang, is probably the person to ask. And there may be others I can find who have the expertise, but I'll try to avoid answering those questions about machine learning. So there is another recommendation. I'm just sort of slipping into the parenthesis for regression models, and that's your sample size is more than a few hundred, and you have continuous variables. There is a pretty strong recommendation out there to try and fit the curve. And the technical term is using polynomial terms, or one of the many different kinds of splines in the model. And those are basically ways of, getting away from the linearity assumption. So, and really to fit the data much better. And then the other recommendation is to follow this up, as I mentioned previously, with this sort of internal validation of using either a bootstrapped approach or a k-fold, maybe a 10-fold cross-validation approach. Again, this is just a mile-high presentation today, so I'm not going to get into the weeds of what those are. Next slide. Okay, so this is just a list of popular methods for regression modeling. So the top three are used very often, and they're very acceptable for prediction modeling. Lasso type called lasso regression has become somewhat popular in the last 15 years or so specifically for these kinds of prediction modeling, and it's a way of both selecting variables to reduce the number that are important, as well as applying what's called shrinkage to the estimates. That the technical thing that I don't want to get into, but the idea of it is to make that model equation more realistic, and not so be dependent on little idiosyncrasies in the data that you have. And then there are other kinds of models that are used for prediction modeling, ridge regression, elastic net regression, boosting, and it wouldn't, every time I look, I see a whole bunch of new methods coming out there. It's sort of like a method of the week. I don't, as you might guess, I really don't know the distinctions between all those methods. I do end the slide here with a quote from a recent literature review on that covered, among other things, multivariable modeling and selection of variables. And you'll see from the quote there that they basically, say, who knows? We don't know what works better. I think the quote is a little bit too pessimistic. There is some evidence that certain models work better in certain circumstances, but there's still a lot more work to be done by, tenure track statisticians to kind of flesh out which kinds of models work best in which situations. On the other hand, I think one positive about that is that the fact that it's not clear which models work best, it means that it may not matter that much which you choose. No doubt there will be one model that truly is the best model, but it may not be that much better than the second or third or fourth best model. So if you're planning to stick with the simpler stuff, logistic regression or something, that may be just fine. So let's see, another question. Oh, okay. So next slide. So machine learning approaches. So I just saw this yesterday. This article it's an editorial in Scientific American. So AI, artificial intelligence, which includes all these neural networks and all the various kinds of machine learning, big data approaches. The headline is that it's overhyped in medicine because these models predict disease and are not as accurate as the report may suggest. So I did read read it, and the concern is that for one reason or another, the models aren't being carefully validated the way they should be. And you really do have to kind of separate out the validation part of the model from the what's called the training part, and that's kind of, I think, what they're assuming, that there's some sort of contamination going on. I don't know exactly why. Anyway, next slide. So
Stan,
how do, yeah.
so you said the concern of inaccuracy is highest with the small studies, but with large studies or very large studies, can you also similarly find things that are just by chance because you have such a large data set that are not actually meaningful?
Yeah, this is getting into territory where I don't think I can answer you authoritatively.
Okay, that's okay.
Certainly, the larger the sample size, the more trust you can have in it. Where any model is going to break down, including the fanciest machine learning model of the largest sample size, is if you're talking about groups that are sort of subgroups that are pretty rare.
Okay.
Because there's just not going to be much data, even in a giant data set. You might have 5 people who fall into a particular category out of 30,000, and I've seen that happen, and
Okay.
the modeling process could make a big difference there.
Okay. Thanks.
Okay, next slide. So this is sort of getting into what's sort of very special about prediction models. So discrimination is how well it separates the groups. For continuous outcomes, it's pretty easy. The standard R square, percentage of variance explained, is often used. The mean square error is also used as well. I'm not going to explain that now. For binary outcomes, let's say you're doing a logistic regression, usually the C statistic is reported. That can typically go from 0.50 to 1.0, and maybe 0.60, 0.65 is getting pretty good. I think the Framingham prediction model, I think that in the general population, or some population, had a C statistic of about 0.70, and that was considered a pretty good model. So calibration is really very unique to prediction models, and that's where you're looking to see how much actual agreement there is in the actual absolute predicted values and what you're finding in the data. And so again, it's if you're, let's say that you had 100 people in the data who fall in a particular category, and 25% of them have the event. And your prediction model is predicting that 50% will have the event. Well, that's a problem there, right? So if it's closer to 25%, we have more confidence. There are different levels of calibration judgment, and again, I think that goes a little bit beyond the study. It depends a little bit, from what I've read, on the sample size. If you have a sample size of maybe 400 or so, you can, or more, you might be able to have a decent calibration curve, which I'll show you in next slide or two. But the other thing is external validation. You can apply discrimination calibration in an external sample if that's something that's an option for you. Next slide. So here's a hypothetical calibration curve from an article I found for internal calibration, meaning that it's it's the same sample. You're not going to an external sample. And if you had perfect agreement between the predicted risk and the observed risk, it would be on that straight line, which is the diagonal. But those two other curves show areas of either underestimated risk or overestimated risk. And there are other statistics that can be useful. Yan, you have a question about is there a rule of thumb for R squared? I was afraid someone would ask me that. I've seen that some places, some people say as a rough rule of thumb, if you can explain 15% of the variance, that's not too bad. But it's a very rough rule. And I think it really, what you'd want to look at is the mean square error, which gives you a sense of how far the actual predicted mean is from the observed means in a particular range. And there, I think it depends on what the standard deviation is of the outcome measure. So it depends on the actual measure you're using. Next slide.
Thank you.
Sure. So this is from the same article. This is a calibration curve based on actual data where it was an external validation. They used a model that was used in some other area of medicine, and they applied it to a completely different sample. And you can see here that that there's a big discrepancy for once you get to a predicted probability greater than about 0.20, that the predicted probability tends to be considerably higher than the observed probability, the observed proportions that you should be seeing. So again, this is recommended it's recommended that you do something like this if your sample size is, I think the rule of thumb I've seen is that if you have at least 200 people who have even and 200 who don't have even, that it's worthwhile doing this. The problem in smaller sample sizes is probably the calibration curve is going to be too shaky. So it may not just be very informative. This particular calibration curve has a, I guess it's a 95% some sort of confidence band around it. So it's not too, it's narrow enough to be useful. If you found that the confidence band was quite wide, then it's just not going to be informative. Next slide. So almost done. Sample size requirements. So there is an old rule of thumb which says that you want to have a minimum of 10 people per degree of freedom. So if you have, that might correspond to 10 predictor variables, but if you have a predictor variable that's a categorical variable with 10 levels, that variable would have 9 degrees of freedom. So this is kind of a minimum. It's been around in the literature for many years. And then what I mentioned about the calibration curve, there are better formulas out there now. Some work has been done more recently in the last few years, but it's much more complicated. And and I wouldn't be happy. I don't want to spend 5 hours talking about it. So if it would probably be worth something doing for a big grant, an NIH grant, you really feel nervous about being able to justify the sample size that you're using. That's when it really, I think, would pay to use the fancier method. And you can contact me if you want a reference on that. Next slide. So these are just my own general recommendations. So I would recommend, if you're planning a study, to read the guidelines that are in the tripod statement, which I think I put in the reference list that's on the last slide, or you can Google it. Tripod statement is a reporting guideline, just like as many of you may be familiar with the concert statement for randomized controlled trials. I think there are probably 200 or 300 of these statements out there. The tripod is pretty good, actually. It's really well thought out, and you actually you go through it, I think it'll actually help you in planning your study because it goes into some of the issues I've discussed in actually a lot more detail. Um, again, decide on your list of variables depending on how you anticipate being used. Choice of method may not be critical, though, if you're working with someone who's a statistician or, has experience with some particular method and they really like it, they think that, neural nets is the way to go or some fancier method, I think that's fine. But the lasso seems to be where the literature is heading is, pretty decent fallback. I've only used it a couple of times. I actually didn't find it to be as useful as I hoped, but it may have just been the particular samples that I was dealing with. And finally, this may seem negative, but I'm trying to make it positive, which is, let's say you start off doing a study and you find that the discrimination calibration seemed just really bad. Well, maybe just skip the prediction model part and just make it into a regular regression sort of model paper. So your time and effort haven't been wasted. Make use of what you've got, because the truth is many times these prediction models, unless you've really been lucky or thought it through and gotten just the right variables, are not going to be that useful. A fraction of them will be extremely useful, but you won't know until unfortunately, until you actually do the analysis. So, and then I think the last slide are just some references. Another slide, Vivian? Yeah. So the tripod statement is that's the explanatory one. It's a very long article. It doesn't have the pages here. The Sauerbrei is the one that talks about selection of variables. And the last one goes into a little bit more detail on calibration and the fact that people need to be doing it more often. So that's it. So not surprisingly, I went over my time frame, but we do have a few minutes. And for people who don't have time to ask me questions now or don't have any questions, but have something in the future, just send me an email. And again, if I can't answer it, I'll see if I can find somebody like Wally Yang who can. So any questions for these last few minutes?
So Sam, I have a question regarding the last statement you made about if your calibration, if kind of your metrics are not up to par for prediction, but to go ahead and to try to publish it just as a standard regression. So do you mean just publish it as these are associations as opposed to this is predictive?
That's right.
Okay.
I mean, you can still say that certain variables are predictive,
Okay.
but you wouldn't go to the next step and saying, well, here's the formula that you should use. And, and here's a website where you can key all this in and out will come, the probability that somebody will have event X. So it becomes sort of a little more like a standard, observational epi kind of risk factor study, for example.
Yeah. Okay.
And yeah. Any other questions?
Any questions from anybody? So I'll ask another question. So the C statistic that you mentioned that gives you kind of an estimation of how accurate your point estimate is for the probability. Is that something that comes out on all regression models, but you just use it when you see it, when you're trying to use it in this context? Or do you have to key in, specific things in SAS or R to get that C statistic?
If you're using a logistic regression model, it will automatically give
it always comes out. Okay.
Yeah. Whether, a lasso regression will give it to you, whatever, it probably depends on the software.
Okay.
Sometimes it'll be labeled area under the curve, AUC. And, Again, I've seen some very rough guidelines, you know, if it's 0.65 to 0.75, it's really good. But, to me, it's a very abstract number, and I think
Mhm.
that's why it's, even some methodologists aren't, you know, they use it, but, and there is a pretty strong evidence in statistics that you don't want to compare models based on that statistic.
Okay.
Because, in other words, sometimes people will say, well, oh, I've got this cool biomarker,
Mm.
it's the molecule, and I'm measuring it. And I bet you that's really adds to the prediction a lot. It could be, there are many instances in which that biomarker could be really important, very helpful in prediction and in shifting the predicted probabilities, but it might shift the area under the curve, the C statistic, from, you know, 0.60 to 0.61.
Yeah.
And, you know, it's like, oh, well, that's a waste of time. And it's really,
Mhm.
and so it's just not good for that purpose.
Okay.
And there are other, you know, there's a whole slew in the literature of other statistics like this out there. I mentioned the C statistic because it's the most common
Mhm.
one that's reported, and it's pretty easy to find.
Okay. Great. Any other questions? And Jan, I think you and Sam may need to discuss when the rest of us are not around with higher level biostatistics talk. But thank you for all your questions. Yeah, and thanks, Sam, for going through this. It does really help, I think, to think about some of the limitations we may have with smaller data sets, et cetera, and thinking through when we might actually want to try to do this.
Okay, it was fun doing this.
Yeah, thank you. Well, thank you, everybody. If there are no other questions, we'll go ahead and wrap up. And the talk will be on our website, so you'll be able to refer back to this. Thank you so much.
Thanks, Sam.
Okay, bye-bye.